Good afternoon, everyone. My name is John Gallo. I'm the Chief Executive Officer and Executive Director of Legal Aid Chicago. Welcome to our 5th session in our series on the emerging legal crisis facing Chicago's Black and Brown communities. Our session today is going to focus on long-term care issues. So with that, it's my pleasure to introduce our host today from our longtime partner law firm, Catton, Gil Sofer, who runs the Chicago office of Catton, and Jared Heck, who is on our board of directors. Gil and Jared.
Thanks, John, and hello, everybody. Good afternoon and welcome. My name is Gil Sofer. I'm the managing partner of Chicago's Catton office, and we are really delighted to be hosting this presentation today. As John has suggested, we've had a very long, very productive relationship, very rewarding relationship with Legal Aid Chicago. It stretches back to the early 90s and even earlier, even before we established our pro bono program here at Catton as it exists today. There are too many projects, too many initiatives that we shared with Legal Aid Chicago to catalog here, but let me just call out one of them. We're particularly proud of our collaboration on the Day Diego Clinic. It is a remarkable program in which our lawyers have and continue to give advice and counsel to people who otherwise couldn't afford it. It's just one of many programs we do, but it's enormously successful. And we're doing it even now, even in the world of the pandemic, we're doing it remotely, and I think it's coming off very well. So we're proud and thrilled to be doing that. We are thrilled to be hosting today, and I hope everybody enjoys the program. And just with that, I think I'll hand it off to Jared, who will make some introductions.
Hi, everyone. I'm Jared Heck. I'm a partner at Catton. I've personally been involved with Legal Aid Chicago now for more than 15 years. About 14, 15 years ago, I served as a Pilley Fellow in the former Wicker Park office, and now I'm proud to serve as a board member and a regular participant in the Day Diego Clinic, which has been a tremendous success. Over the past 15 years, I have witnessed the significant impact the fine attorneys, paralegals, and staff of Legal Aid Chicago have made in our local communities and those outside of Chicago. Today, I'm excited to learn about a new area of law for me, that being long-term care issues. We are fortunate to be joined by a panel of experts. Kelly Richards of Illinois' long-term, or I'm sorry, I should say she is Illinois' long-term care ombudsman. Suzanne Cortu, a supervisory attorney in the Ombudsman Project at Legal Aid Chicago, and Lawrence Wagner, also a supervisory attorney in the Ombudsman Project at Legal Aid Chicago. With that, I'm going to turn it over to Kelly Richards to get us started.
Good afternoon, and thank you for the introduction. I'm delighted to be here to talk to you all this afternoon and give you some little information about the Ombudsman program and to talk just a little bit about our efforts during this COVID pandemic. Again, my name is Kelly Richards. I serve as the state long-term care ombudsman. I've been serving in this role since May of 2019. And prior to that, I served as the deputy ombudsman. And prior to that, I worked for the Department of Human Services in various managerial positions. So overall, I've been working for the state of Illinois close to 22 years now. So again, I'm delighted to be here, and I'll begin to jump in and talk a little bit about the Ombudsman program. So the Ombudsman program is a resident-directed program. The federal and state laws give us private interactions with residents and access to facilities. So as it relates to who we serve as representatives for residents who reside in long-term care facilities and participants who receive the Medicaid and Medicare managed care services and participants who receive Medicaid waiver services. So when I refer to participants, I'm referring to persons who receive home and community-based services. As it relates to our mission is to ensure older persons and adults with disabilities receive quality services and live a dignified life at the highest level possible. Next slide. On this slide here, it outlines the different facilities that we have jurisdiction to go into. We have jurisdiction to go into 8 of these facilities to meet with residents, to talk to them about their rights, and to follow up on any complaints that they have, and investigate and try to come to a resolution for the residents. In our next slide, we talk a little bit about the program structure. Our program is housed within the Illinois Department on Aging. And within our program, we have the long-term care program, which we call the traditional program. And then we also have the home care ombudsman program. The local ombudsman program are operated through various provider agencies. And Legal Aid Chicago is one of the provider agencies that house the long-term care ombudsman program for suburban Cook and Lake County. And the Illinois Department on Aging and Legal Aid Chicago have had a long-standing partnership, and we're very thankful for that. So within the local program, we have the regional ombudsman, which is Suzanne and Lawrence. And then there are long-term care ombudsmen. They're either paid ombudsman or volunteer ombudsman. So this slide here just represents the 13 program service areas that the Illinois Department on Aging has. And in the long-term care ombudsman program, we actually have 17 regional programs. There are 4 programs that are within Area 2, and then Area 13 has 2 programs. Next slide. As it relates to residents' rights are woven throughout the federal and state laws. We get our direction or our mandates from the Older Americans Act and the Illinois Act on Aging. Next slide. Ombudsman advocacy, I want to talk a little bit about this as it relates to our work. In our advocacy efforts, we typically meet with residents one-on-one. Again, our program is resident directed. If we can't get direction from a resident, we'll take direction from their authorized representative or their guardian. Ombudsman will never take action without permission of the resident or their representative. Complaint resolution and problem solving are the means that we use to assure that residents and participants' rights are understood and honored. Ombudsmen work to empower residents and educate residents and staff on residents' rights. Ombudsmen are not mandated reporters. Next slide. And the reason why ombudsmen aren't mandated reporters is because we take directions specifically from the resident. So we cannot be mandated reporters. And again, we work to resolve any complaints that residents have to their satisfaction. So if a resident decides that they don't want us to follow up on a complaint, then we will end up making a hard stop and not following up on anything based on what the resident has directed us to do. The next slide. The next slide is about ombudsman access. Ombudsmen have, ombudsmen have the right to enter facilities 24 hours a day. But COVID has changed that a little bit because we were prohibited from going in starting in March as a result of the COVID pandemic. We received guidance from CMS in relationship to the visitation for residents. So we've had to suspend our visits to residents. However, we're slowly moving back in that direction. Facilities should never interfere with residents' rights to visit with the ombudsman, and only the residents can deny access to him or herself. No one else but the resident can do that. So there are times when a guardian or a power of attorney may feel like the ombudsman is interfering and we cannot interact with the resident, but it is actually the resident who makes that determination on whether or not we have access to meet and visit with them. Next slide. The next slide talks about IDPH's role and the ombudsman role. So as indicated on this slide, IDPH are the regulators and we serve as advocates. We advocate for quality of life and care of residents. And IDPH really works to assure that nursing homes meet their minimum standard. Next slide, please. In this next slide, we just want to talk a little bit about the Ombudsman program and our efforts to still maintain our work with COVID. So our mission has definitely remained the same. We've just had to pivot a bit or shift a bit in terms of how we do our work. And so some of the things that we have done are illustrated on this slide here. We've printed various materials. We've created postcards and flyers and consumer fact sheets that we've distributed to families and friends and residents in the facilities to let them know that the ombudsmen are still here, even though we can't get into the facility, to still advocate for whatever their issues or concerns are. And again, I would just like to point out that initially back in March, CMS had issued guidance indicated that visitations to facilities should be suspended in an effort to mitigate the transmission of viruses, the COVID virus within the facilities. So we had to shift a bit and begin to do our advocacy efforts over the phone, doing virtual visits with residents or family members, facility staff. We have done virtual resident council meetings and family council meetings as well. We've created, we've been a bit creative, if you will, as it relates to participation in bingo nights at facilities with residents, just as a way to stay involved and connected with residents and to let them know that we're still here, just to tell them about the services that we offer. There are some programs that have been able to tap into closed circuit television to do a little presentation or a slideshow about the Ombudsman program, and just to let people know that we're still here, even though we're not being able to see residents face to face. And then after that, we began slowly doing window visits and outdoor visits. We started our window visits back in April, and depending on the area, because there are 17 programs throughout the state, those window visits weren't always conducive because of location and how the physical structure of the building was set up. And then we slowly moved to outdoor visits, and for the most part, I believe that all of our programs presently are doing outdoor visit in some type of capacity. And during those visits, we have an opportunity to meet with residents privately and to talk about whatever their issues are, to check in with them. Sometimes their family members may be present as well, to discuss whatever issues that they have with the residents' care. When we go to do these outdoor visits, of course, we're taking these postcards and flyers and dropping them off at the front desk to let people know that we're still here, that they can meet with us in person. I wanted to also add that in August the 14th to be exact, IDPH issued guidance as it relates to re-entry, and in that guidance, it stipulated that ombudsmen should be considered state authorized persons who can enter to visit with residents, and we're not considered as the traditional visitors. So we are slowly moving back to doing our face-to-face visits with residents at this juncture. Next slide, please. I believe on the next slide, it just outlines additional resources that are out there that are available for people who want to know a little bit more about the Ombudsman program. We have the Consumer Choice website. That's a link that consumers can use to find a specific facility that they or their loved one may want to enter into. And then the last link is for the National Consumer Voice, and that website is a resource that ombudsmen can use, that consumers can use to go to find resources about long-term care facilities, about residents' rights, about discharges. There are a whole host of resources that the National Consumer Voice has. So I would encourage anyone to click on these links or go to these links, to get additional information about the Ombudsman program. And I believe our last slide here is just a contact information for myself. And then LaRonda Williams is the Deputy State Home Care Ombudsman, and Chuck Miller serves as the Deputy State Ombudsman, and he works closely with me. And then the last number indicated here is our senior helpline. So if someone is interested in finding a specific ombudsman program or has questions about the ombudsman program, they can call that number or email any of us at the numbers listed above. And that will conclude my presentation. I will pass it on to Lawrence and Suzanne, who will talk a little bit more about long-term care issues as it relates to race. Thank you.
Thank you, Kelly. As Kelly indicated, my name is Lawrence Wagner. I am a regional ombudsman and one of the 2 supervisors of the Ombudsman Project here at Legal Aid Chicago. Kelly also mentioned that the state is divided into 17 ombudsman coverage areas. Of those, the Ombudsman Project at Legal Aid Chicago oversees the long-term care facilities in Lake County and suburban Cook County, except Evanston. Evanston has its own Ombudsman Project. Long-term care facilities are the types of congregate living that has made residents at those facilities more susceptible to COVID-19 than the general population. In Illinois, as of August 21st, 2020, 4,319 deaths of residents in long-term care facilities have been attributed to the virus. That's 55% of the overall death toll in Illinois. Factors contributing to this higher death toll are that residents tend to be elderly, largely over 65 years of age. They tend to have various underlying conditions which would exacerbate the virus once they have it. And they all live in close proximity to each other. And this is especially the case if the resident is on Medicaid, which most of them are. They will have at least one roommate. Depending on the size of the facility and the layout of the facility, they may have up to 2 or 3 roommates in the same room. Also adding to the problem is that residents receive care from staff who tend to go from room to room, often with little or no PPE or inappropriate use of PPE. Those same staff often work at multiple facilities where they have the same conditions as the last facility they left, and the staff tend to go home to their communities, and those communities are largely communities of color, which, as we know, have also been harder hit by the pandemic than other communities. So you add all those things together, and it's easy to see why the COVID virus has hit long-term care facilities harder than other places. As far as COVID and race goes, we've heard the reports that nationwide there's evidence that COVID-19 has disproportionately affected communities of color. We don't know necessarily how that translates to residents of long-term care facilities, because we don't have demographic data about long-term care residents who have contracted COVID-19 or have died from it. If IDPH or anyone else is collecting that data, they certainly are not disseminating it, so we're not privy to it. However, in the facilities themselves, there is no evidence to suggest a correlation between race and instances of COVID-19. But given that in the long-term care context, the virus seems to be an equal opportunity infector. What we have found, though, from looking at different surveys of facilities, we have found that skilled nursing facilities in the area that we serve, there is a strong correlation between the race of residents and the facility's overall quality rating. We found that as a percentage of non-white residents in the facility increases, the average number of hours worked by registered nurses decreases. And the average total staff hours per resident also decreases. The average quality ranking for facility also decreases. The average percent of Medicare patient days decreases, and this chart shows a bit of what I'm talking about. The average percentage of Medicaid patient days increases. Nursing hours as a whole, staffing hours, and quality rankings are all indicators of the quality of care available at any given facility. And the data has found that facilities with a 1-star rating, as CMS rates facilities, those 1-star facilities tend to be even in terms of the number of Black and white residents they serve. However, when you look at 5-star rated facilities, the population in those facilities tend to be 94% white and 4% Black. In this slide and the next slide are graphic representation of that data. So where does Legal Aid Chicago fit into all this? Next slide, please. Our Ombudsman project is comprised of a team of 3 attorneys, 15 community ombudsmen. Those are the folks who go out to visit the facilities and really do all the hard work, and 1 intake specialist. Our relationship with residents is confidential in much the same way a lawyer-client relationship is confidential. During normal times, we would maintain a regular physical presence in all the facilities we serve. Between Lake and Cook counties, that's a total of 318 facilities with about 36,740 beds. So there are a lot of folks out there that rely on us and our advocacy and the things that we do to solve the issues they have relating to care and even Medicaid and Medicare. As Kelly indicated, we advocate for their health and welfare. We empower residents to advocate for themselves. And our activities are basically resident directed or directed by their agent who is authorized to act on their behalf. We respond to complaints that come into either our hotline or that our ombudsmen themselves observe when they're visiting facilities. And anyone can make a call to our hotline. Calls can be anonymous if the caller chooses to be. It can come from a facility staff, from a family member, or even from the resident him or herself. And I want to emphasize something that Kelly pointed out, is that our activities are resident directed. And this goes back to part of the confidentiality nature of the relationship. Even if we as ombudsmen see something going on in a facility that we think needs to be addressed, unless the resident gives us the permission to address it, we cannot do it. And that's mainly because we are not mandated reporters, and we're not mandated reporters because of the nature of our relationship with the residents. Now, as you can imagine, in this COVID-19 era, our roles have become a bit complicated. Like everyone else, we've had to take our advocacy into cyberspace, if you will. All of our physical visits to the facilities have turned into phone calls or video calls where possible. And not every facility is equipped to do video calls, which is what we would prefer. So we work around where we can. There's also the restrictions, Kelly again made mention to restrictions that IDPH have put in place, which kept us out of facilities. And to be fair to IDPH, I think Legal Aid Chicago would also not necessarily want us to enter facilities at this point until we can ensure our safety and the safety of residents that we're servicing. We, like Kelly said, have taken to doing window visits, and of late we've been doing outdoor visits. They're still not ideal, but they're more effective than doing the telephonic or the video visits. And the outdoor visits in particular have the added bonus of giving residents some human contact. Because they've been so isolated during this pandemic, most of them, the only people they come in contact with are the staff members who are providing them with service. And I don't think I'm exaggerating to say those are not social visits, and they don't necessarily go in a way that would appease or allay residents' social anxieties. So when they see us in outdoor visits, it's a welcome thing for them, and they appreciate that contact with another human being who's there and more concerned about their care. These visits are still challenging to us in terms of our traditional advocacy in ways that we don't like. The biggest part being access to residents. We like having unfettered access to residents. As a matter of fact, it's It's our mandate to have unfettered access to residents. However, when we're scheduling window visits or especially outdoor visits, we have to schedule those visits through the facilities themselves. And the facilities have certain rules about when visits take place, how often visits can take place, how long the visits can be, and who can be present at those visits. And most facilities even insist on overseeing those visits in the guise of ensuring that we're following proper social distancing guidelines. Because, of course, this raises issues of confidentiality because those conversations between us and the residents are supposed to be confidential. And whenever you introduce another party in there, obviously the confidentiality is broken. And when it's the resident's choice, that's fine. But when it's the facility imposing that on us, then it is not fine. We also have a more difficult time getting access to resident records, which is important to our advocacy. Each facility keeps notes, some good, some not so good, about care and about incidents in the facility. Depending on what we're dealing with the resident, it's important for us to have access to those records. And during this pandemic time, it's become even more difficult for us to get that information. So it does add an additional level of challenge to our advocacy when we're dealing with our residents. And finally, one of the biggest things that residents are running into now with visits is that IDPH, which regulates the long-term care facilities, has not been investigating complaints as they should. They just recently admitted that they haven't been following their own procedures regarding complaints made from March to June. And at the risk of bad-mouthing IDPH, if they're admitting to problems from March to June, you can just imagine how many problems there are actually out there. And with that, I will turn things over to my colleague, Suzanne Courtois, who will present the remaining slides.
Hi, everyone. This is Suzanne Courtois. I'm one of the supervisory attorneys in the Ombudsman Project at Legal Aid Chicago. Today is actually my 7-year anniversary with Legal Aid Chicago, and I've spent all that time in the Ombudsman Project. So the main issues that we've seen come up during the pandemic for long-term care facilities are exacerbations of existing issues. Next slide, please. We're existing issues about staffing, infection control, facility-initiated discharge, and social isolation. Next slide. So staffing is an indicator of quality in a facility, particularly the number of nursing hours per resident, direct care staffing hours per resident, whether a facility uses in-house staff or has temporary staff from agencies, and the level of training of their staff. Similar to what Lawrence was showing us regarding quality measurements in facilities, you can see that in facilities that are less than white, the registered nurse staffing hours are less than half of what they are in facilities that are more than 95% white. It's not quite as dramatic in direct care staff hours for the facilities that are less than 50% white versus 95% white in direct care staff, but it's still a big disparity, 2.6 hours per day versus 3.33. That makes a big difference in care. During COVID-19, these staffing issues have been even more acute. The staff see the jobs in nursing homes as dangerous right now. They're frontline workers. They're in facilities that are many facilities that are dealing with COVID outbreaks. And in general, in the past, especially for CNAs, certified nursing assistants who do a lot of the direct care for residents, that is not always that is generally not a particularly well-paid job. There have been some there have been some updates with that as facilities have scrambled to have staff, but in general, it's been what we're hearing from facilities is it's hard for them to keep staff, and they've had to deal with staffing shortages when their staff contracts COVID or has to quarantine due to COVID exposure. In addition, right now, certain federal regulations regarding staffing at skilled nursing facilities have been waived by the federal, including training requirements that that in normal times require CNAs to complete training by 4 months into their time at the facility. They're now don't have to meet that requirement. And for the first few months of the pandemic, facilities did not have to follow their did not have to provide their staffing information. That waiver has been withdrawn as of the end of June, but we will never know the staffing levels unless voluntarily provided for facilities between March and June. Staffing has a huge impact on residents. When there's not enough staff, it affects the time for answering call lights. It means that residents have to be changed. So they're sitting in soiled products for a long period of time, which is not comfortable. There have been issues with distributing meals and medications. We heard from one facility that no residents got breakfast at a facility until after 10 a.m. one day. That's one of many stories we've heard. We've also heard of serious problems with distributing medications distributed late or not distributed at all for certain periods of time. During COVID, lack of staffing also has been a problem for lack of access to phones. Usually, in many of our facilities, residents don't have a phone in their room, and if they have a cell phone, they have to pay for it. So many residents, their only access to a phone is when a staff member brings the phone for their hall to their room and lets them use it. And so, and because they're not allowed to have visitors right now, that access to phones, that's their lifeline to contacting their loved ones. There are also serious issues with illnesses and injuries caused by untrained staff. If a staff member doesn't know how to properly lift a resident out of a bed, there can be falls and serious injuries. There can be all sorts of problems caused by staff who don't have proper training. The Ombudsman interventions that we can do include, we attempt to address the issues that are brought to us. So if a specific resident brings us a complaint about a specific staffing issue, the people who have been helping them don't know how to properly lift them, and they feel like they've been hurt by being lifted improperly, or not allowed to. Or we've heard from residents that they haven't been allowed to get out of bed, or haven't been able to get dressed because of a lack of staff. We will try to address those particular issues. As Kelly and Lauren said, we're resident directed, so we can only act when we have resident consent. And sometimes residents don't want to get consent. Retaliation in facilities is common and doesn't have to be as serious as trying to discharge a resident. It can be anything. It can be as small as you used to be the first person to get lunch, and now you're the last person to get lunch, and so you're waiting an extra 45 minutes to an hour before you're served. And that's the kind of retaliation that's almost impossible to prove. We try to empower residents. We also use tools at our disposal, like working through the care planning process that facilities are required to engage in to figure out what best way for a resident to achieve their highest practicable level of functioning. And that care plan process can include making sure that the staff that work with residents are aware of specific issues they have. We also advocate for changes to how things go. If a resident has an issue with a particular staff member, sometimes the advocacy is making sure that that staff member doesn't work with the resident anymore. We also, in general, try to get at the underlying issues of complaints. However, where the underlying issue is lack of staff, it's one of the most difficult problems for us to get at because staffing is largely a financial issue and have no control over the finances of the facilities. Infection control there's been a spotlight on infection control in the, during the pandemic, but infection control has been a persistent problem at facilities even before the pandemic. In May, the GAO released a report that analyzed data from the Centers for Medicaid and Medicare Services, the federal government, on infection control. It showed that 4 out of 5 skilled nursing facilities nationally were cited for an infection control deficiency in 1 or more year between 2013 and 2017. And about half of those facilities that were cited had the same citation multiple years in a row. So this is a persistent problem, and everybody's working on it now, but it's something that existed before COVID brought it to light. Infection control, excuse me, sorry. Infection control right now, the CMS ordered infection control inspections at all skilled nursing facilities by July 31st, or IDPH surveyors, the inspectors would not receive the rest of their CARES Act money. So we assume that those happened. There have also been some hit and miss attempts at infection control from the federal government. There was a point where every skilled nursing facility in the country was supposed to get 2 weeks worth of PPE. Some of that PPE was perfect and useful, and some of it was defective or not the proper PPE for a nursing home situation. Similarly, there have been evolving standards about testing in facilities, and a lot of confusion about how that testing was supposed to happen and what facilities were supposed to do with the information once they got these tests back. So it's been an evolving process, but infections in facilities are slowing down. In May, there were over 500 COVID-19 infections in nursing homes per week in Illinois. By late August, it was less than 100 per week. So that's a dramatic improvement. There's still a long way to go. All right, and facility-initiated discharge. This is a perennial issue. This is something that our program regularly represents residents who are fighting facility-initiated discharges. But the facility-initiated discharge process has just been more traumatic during a pandemic, during a time when a resident doesn't know where they might be going, or if the next facility they're going to has an outbreak, etc. So soon after the pandemic started, CMS issued a number of waivers. One of the waivers was they waived the requirement for skilled nursing facilities to issue a 30-day notice for involuntary transfers or discharges. Transfer discharge was solely for cohorting purposes, for putting residents who are COVID positive together and taking residents who are COVID negative away from people who are COVID positive or potentially positive. It meant that someone could be moved from their facility where they've been living for potentially years to another facility with no choice, based on their COVID status, and they had no recourse for that. These cohorting transfers include a facility that was a CMS 1-star facility became a COVID positive facility, and residents from all over the Chicagoland area were being sent there for COVID treatment without any choice. Facilities can also send residents to another facility for 14 days of isolation if they if the home facility doesn't have the space for it. We had a resident who was sent to the hospital for a medical reason, not COVID. And after she was discharged, her skilled nursing facility sent her to a facility for people with serious mental illness for observation. That facility was very scary to our resident. She did not like being there, and no one would give her a time frame when she was actually going to be sent back to her original facility, even though this isolation is supposed to only be for 14 days. No one would talk to her from her old facility, and she ended up discharging before her rehab was over because she didn't want to be in this mental health facility anymore. That has happened to several of our residents who have been sent to different facilities, including mental health facilities that they found scary. We've also seen, so our work on the Ombudsman Project's work on facility-initiated discharge cases includes that skilled nursing and assisted living facilities are required to send us the notices that they issue for, including now, as long as it's not based on cohorting. And we make those residents aware of their rights, including their right to appeal the notice of involuntary discharge. Those appeals happen through an administrative process before the Department of Public Health for pretty much all our facilities except supportive living facilities, and HFS for supportive living facilities. We also represent residents in discharge hearings on a regular basis and handle that legal proceeding for them. So soon after the pandemic started, we had a case where a facility would not allow a resident to return to the facility after hospitalization for COVID. Ron went to the hospital for an alleged suicide attempt in April. He developed COVID, recovered, and tested negatively twice by May. His facility refused to allow him to return, even though he was entitled to the next available Medicaid bed. The ombudsman intervened, and the facility allowed him to return to his facility, and which is where he wanted to go. We've also seen facilities take advantage of the situation with COVID and use this as a chance to try to get rid of residents that they don't like anymore. We had a resident who I'll refer to as Penny. Penny is lovely and thoughtful and soft-spoken. She's also suffers from MS, and as a result of the MS, she is quadriplegic. She can't move her legs and only has minimal movement in her arms. She can't move a hair out of her face. She literally could not have heard a fly, but she also had a camera in her room to record what was going on. That camera was allowed by statute, and she and her family made a lot of complaints about the care she received, which were backed up by the footage from this camera. And the facility didn't like that she made all these complaints, even though she is statutorily allowed to make these complaints. The facility deemed her a safety risk. Safety risk is a basis for involuntary discharge, but it's usually meant for when a resident is a physical threat to others in the facility. Penny couldn't hurt anybody. The facility said that she threatened this because she made complaints. She was threatening to the staff, and the facility deemed this an emergency, even though the video footage showed that in the hours before they sent her out to a behavioral health hospital, to a mental hospital, she was sitting quietly being fed dinner by a CNA watching Wheel of Fortune. We represented Penny in her involuntary discharge hearing before the Department of Public Health, and the day that the facility was required to turn over its documents, they capitulated and gave Penny the right to return to her facility. The facility was also cited by the Department of Public Health for Penny's case and another case of wrongful involuntary discharge. And as part of their plan of correction, I virtually went in and did an in-service for their staff about what constitutes a valid involuntary discharge. However, even though this was a victory, we won for Penny. She had to go back to her facility. She was sent out of her facility that she had lived in for 5 years. She was sent to a behavioral health hospital and then sent to a facility an hour and a half from her husband. And as a result of all of the stress, she had a serious exacerbation of her MS and was in serious pain for weeks afterwards. So now we come to social isolation, which is the big effect on nursing home residents that is not being talked about right now. We've all heard about the COVID infections and the deaths, but in order to combat those COVID infections and deaths, CDC, CMS, IDPH, all initially advised facilities to disallow all visitors except for compassionate care situations. And compassionate care has been interpreted in a very limited manner. Most facilities are only allowing compassionate care visits for residents who are actively dying. So residents have largely been cut off from family and friends. Kelly and Lawrence talked about how window visits and outdoor visits have started, but those are limited. So many residents have spent 6 months, mostly in their room, with limited access to phone, maybe a few outdoor visits with family and friends, maybe a little time outside. And the only people they see on a daily basis are staff providing care who are wearing masks. They're in PPE. And so, you know, the residents are hugely isolated, and it's taken a huge toll on the mental health of a lot of our residents. Mental and physical health of a lot of our residents. So Kelly and Lawrence both talked a lot about window visits and outdoor visits. I'm gonna move on. So part of the social isolation that's been going on is when CMS waived regulations at the beginning of the pandemic. One of the regulations they waived was requirements for giving residents notice of room changes, making sure that residents consent to certain room changes. Those have been put on hold for purposes of cohorting residents who have COVID-19 or may have COVID-19. So right now, the facilities aren't even required to let married residents live together, which can be very traumatic to residents who have had their spouse with them all along and now are separated. Now, most facilities are doing what they can to keep married couples together, but we have seen situations where people who have been living together for a long time, who get along, have been torn apart, and they have no choice in it. They get no notice. They're just moved. There's also no requirement right now for communal activities, which again makes sense, but cuts off resident access to any feeling of community. Many facilities are even limiting residents' doctor's appointments. Most facilities are making sure as much as possible is done by telemedicine, which makes sense. But again, residents are not getting out of the facility much. Many facilities are limiting movement outside of rooms, including the ability to go outside. We've seen a number of facilities where residents are not outside at all or are allowed outside for 15 or 20 minutes a week. We've also seen situations where residents are allowed to smoke several times a day, but the non-smokers are only allowed outside for 15 minutes a week. So the effect on residents has been profound. Some residents aren't able to understand what's going on. Many residents with dementia, many residents with developmental disabilities, some people with serious mental illness just can't understand what's going on and why these regulations have been put in place, why their family members can't come see them, why they can't go out of their rooms as much. And it's been extremely stressful for them. Whether residents can understand what's going on or not, the restrictions, especially regarding residents with visits with loved ones, are having a huge effect. We've heard tales of huge weight loss when family members finally see a resident after many months. The resident is looking gaunt. They've lost a lot of weight. We had a situation reported to us from a family member who said that he went to his mother had advanced dementia. He went to her facility every day to feed her prior to the pandemic. After visitor restrictions were put in place, she refused to eat, and the facility would not allow him to come in and feed her as a compassionate care exception. And that resident passed away. She wasn't eating. We've also seen heard reports and seen issues where residents are having what facilities refer to as behaviors. Residents acting out because there are all these restrictions put in place that they don't understand, and they feel bad, and so they are acting in ways that the only ways that they are able to express. There are also some perverse incentives. I mentioned that there are some facilities where the smokers get to go outside a lot and the non-smokers don't get to go outside. We've heard about people taking up smoking to get some fresh air. So all of this has been hugely harmful to residents, and it's very difficult for them to take any action because they're stuck in their room all the time. So our response as Ombudsman has been advocating for specific residents as we get cases. We've been advocating for loosening some of the restrictions in safe ways, allowing residents socially distanced time outside, potentially expanding the compassionate care exceptions to allow visitations where residents really need the support. We've also been working on connecting residents. Making sure that residents had pen pals. We were able to organize a Zoom resident council meeting for residents of a supportive living facility for people with for younger people with disabilities. We also have had plans to call bingo remotely and remind residents that we're around. We've also been able to bring attention to some of the issues facing residents, including 2 members of our staff, Shrishti Deer, who's now a DePaul law student, and Rachel Schwartz, wrote an op-ed in the Tribune to let people know how difficult this situation is on residents. So with that, that's the end of my presentation. I will pass things off to Melissa to talk about pro bono opportunities.
Thank you, Suzanne. And the work that you are doing to advocate for the rights of individuals in these facilities is so critically important at all times, but particularly during this challenging time. And so much of the work that we do at Legal Aid Chicago involves advocating for those who need help enforcing their rights and advocating alongside of them. For those of you who may want to help do that, I'm going to highlight some of the ways that you can get involved in Legal Aid Chicago's work. At Legal Aid Chicago, we have over 20 different volunteer opportunities across the agency. Our volunteers work alongside us to help meet the needs of clients and are essential to helping us achieve our mission of bringing about justice for all. You can see here the impact that our volunteers have made in 2019 alone. We have a variety of opportunities available, offering everything from a commitment of a couple of hours at a help desk to a longer term representation. And many of our opportunities are available fully remotely. We have opportunities that span our practice groups and subject matters, including the Volunteer Long-Term Care Ombudsman Program, This is a great opportunity for attorneys and non-attorneys to be able to work directly in facilities and advocate for residents. Per state regulation, we provide comprehensive training to those who are interested in this opportunity. And our volunteer ombudsmen are asked to spend a minimum of 4 hours per month in the facility that they're assigned, though many of our committed volunteers spend far more than that. During the pandemic, we are not requiring volunteer ombudsmen to visit facilities in person, and we're working on creative ways to connect with residents, as Suzanne just highlighted, and we welcome additional volunteers who can work alongside us as things improve. You can find more information about all of our volunteer opportunities on our website, and you're welcome to reach out to me with any questions that you may have about any of our opportunities and how you might be able to help. And now I'll turn it back over to John Gallo.
Thanks, Melissa, and thanks to Kelly, Suzanne, and Lawrence for those presentations. We appreciate it. Kelly, we also are honored to continue to partner with you in the ombudsman work that you're doing, and we're grateful for your leadership in that space. So this concludes the planned content portion of today's presentation. A quick update about our Relay for Justice, which is nearing its end. I just checked before this video. We are over 6,000 miles and have over 400 participants as we've been crossing the country with stops marking vital moments in our civil rights, civil justice history. Our second aid session, which is trivia night, is tomorrow. We hope you can participate in that. And as we ramp up to end the relay, our staff itself is participating in its own March for Justice this Friday afternoon downtown. So we will be carrying the metaphorical torch of justice ourselves on Friday afternoon.
Thank you, John. Although I'm doing the Q&A, not Suzanne. So Suzanne's voice didn't suddenly change.
We'll let it slide. We'll let it slide. Go ahead, Lawrence.
Thanks, John. First question is, how is the quality of care of long-term care facilities measured? Are these measures and results publicly available? How are residents protected from retaliation if complaints are reported? I guess that's 3 questions.
So how is the quality of care of long-term care facilities measured? There are a number of different measurements. The CMS ratings that we referred to in this are based on a lot of different factors that are put together by CMS, the Center for Medicaid and Medicare Services. But in general, staffing levels go into it, the amount of complaints, as well as a number of other the facilities that are offered, the activities. A number of different factors go into those measurements, and people quibble all the time about whether they're appropriate. Also, how are residents protected from retaliation if complaints are reported? Oh, sorry, the CMS quality measures are publicly available. They're on the web. There are a number of other data sets that are publicly available for our data that we put together about race and staffing and race and CMS quality guidelines. We took publicly available data and analyzed it. As for how are residents protected from retaliation if complaints are reported, well, we talk to residents about what they want to do and how we act on their behalf, and we do try to protect them from retaliation. The Illinois Nursing Home Care Act specifically protects residents from retaliation for reporting complaints to the facility, to the Department of Public Health, to the Ombudsman, et cetera. But, and we do try to emphasize that with facilities, but as I mentioned, there are a million different ways that facilities can retaliate, and we can't protect residents from all of it, but we do try and make sure that residents are aware before of what we can do and what we can't before we take their consent to advocate.
Okay, thanks, Suzanne. Another question is, if not mandatory reporters, are ombudsmen permitted to report or parenthetical, or do you report anonymously or discourage that?
Would you like to take that one?
Well, maybe Kelly can take that one.
Yeah,
Are
I
you
can
still there,
take it.
Kelly?
Yeah, I'm still here. My internet is going in and out, so please let me know if you can't hear me. I'll be happy to take it. So again, the program is resident directed. So if we are aware of abuse or neglect, we have to have the permission of the resident to take any action. What we do typically is to talk with the resident. If the resident is adverse to sharing this information with the administrator or sharing this information with IDPH, we continue to try to talk with the resident and encourage them to give us permission if they're not willing to say what needs to be said, so we can have whatever is happening addressed. And, you know, we try to talk to them about the ramifications of not disclosing what has happened to them, and just trying to encourage them and empower them. So we cannot go ahead and step before them and make a complaint without their permission to do so. In extreme cases, the regional ombudsman have reached out to the state ombudsman, myself and my predecessors, regarding those egregious types of situations. And as the state ombudsman, I can make a determination on whether or not we could move forward and make a complaint to IDPH or to the administrator, depending on what the situation is. But because of the tenets of our program, we are bound to honor and respect the residents' wishes. So again, we really try to work with the resident and or their representative if given, you know, if the resident can't direct to address whatever concerns are as it relates to abuse and neglect. So hopefully that answered the question. I don't know if Lawrence or Suzanne wanted to add anything to my response.
I don't have anything to add.
Nor do I. So we'll ask the next question. This one I'll give to you, Suzanne. What are some examples of the kind of advocacy you provide? Tell a story of work you have done, please.
Okay. I've told several in my presentation, but I'll tell another one about a resident who passed away last week, who's quite a character. This resident was issued a notice of involuntary discharge from his facility, allegedly because he had been smoking some pot at the facility, and mostly because the facility didn't like him. He was the resident council president. He ran the facility's garden and would use the garden, the vegetables grown in the garden. There was no pot grown in the garden as far as I'm aware, to make big salads for residents to eat. But he also brought a lot of complaints for himself and other residents to the facility. And we were able to settle his voluntary discharge. The facility agreed that he could stay as long as he didn't do any more pot. This was before recreational pot was legal in Illinois, and he went on to join the Illinois Long-Term Care Council, which to advocate for residents, to be the voice of residents in a statewide body. So.
Okay, thanks. Next question is, how long does it typically take to resolve a matter for the client, and what is the time commitment to work on the case?
So it varies widely. We have cases that we resolve the same day at the facility. A resident brings up an issue they're having. The heat's not working in my room. that we get their permission, we go talk to the janitorial staff, they fix the heat, case closed. We also have cases for residents that have gone on for several years, and those are the exception, and those are largely long-term Medicaid applications and appeals, but often involve involuntary discharges as well. But most of our cases take a couple weeks to a month to resolve. Involuntary discharges tend to take a little longer, a few months.
Thanks, Suzanne. Where can you locate IDPH reports?
This is Kelly. I can take that one. On IDPH's website, I'm assuming that whoever's asking that question is asking in terms of like a complaint that was filed. IDPH is required to post after the investigation has been done and the complaint has been concluded, those findings for those investigations, and also with the annual survey. So there are two different types, and I apologize for jumping ahead of myself. There are complaint survey, and then there are annual surveys, and IDPH posts both the complaint surveys and the annual surveys that the surveyors complete on their website. I can't give you the exact link off the top of my head because I don't know, but the forms that they complete and the findings that are discovered in the complaints are filed on IDPH's website. Maybe Suzanne or Lawrence can provide that exact information, but I just don't know it off the top of my head. I'm sorry.
Kelly, I just posted it in the chat for the person who asked the question, so they should have the link right now.
Perfect, thank you.
Thanks, Kelly and Melissa. Next question, should I direct constituents who are bilingual and or undocumented to the senior helpline, or is there a specific attorney who I should direct constituents to?
I can take that one too. Yes, you can direct them to the senior helpline. We do have folks that work on the senior helpline that speak other languages. So definitely, yes. I think there was a second part to that question that maybe I missed, but the senior helpline would be appropriate.
Oh, here's a dicey question for John. Does Legal Aid Chicago need to sue IDPH for not performing its duties, similar to the lawsuit against the clerk of the Circuit Court of Cook County?
I think, am I on video here? Yes, again. So the answer is, if we're presented with a case that we find meritorious, and as an organization, we think that it merits suing IDPH, we would do so. I mean, the short answer is, if it's the right case, we'll do it.
Thanks, John. Next question. Have you received an increase or decrease in calls during COVID?
So we have mostly stayed about the same. We've continued to receive a steady stream of calls. We've gotten more, we've gone through phases where it's been more calls from family members and fewer from residents. We're getting back to getting calls from residents too. But there have been points where we've gotten fewer, but mostly it's stayed about the same. We keep expecting to get an influx of calls when family members get access to their resident, to seeing residents again. And we have had some of those as people have gone for outdoor visits, but it hasn't been a huge volume.
And I would just like to piggyback off what Suzanne had said for the state office as well. The majority of the calls that have come my way have been from family members and not residents. There may have been a few residents sprinkled in of the calls that I've gotten since March, but a large majority are family members inquiring about not having access to communicate and to see their loved one. And that has been the primary complaint that I've received at the office.
Thank you. Next question. Do we address medical malpractice issues or any other issue relating to adequate medical care? I love that to you, Suzanne.
So we don't handle medical malpractice lawsuits or nursing home neglect lawsuits, but we do help residents who are saying that they haven't been getting good care by trying to help them address the care issues that they're presenting. So a resident who says that, you know, they keep giving me the wrong medication, we're not going to sue the facility for the adverse effects from the wrong medication, but we are going to work with the facility, if the resident consents, to make sure that whatever caused the resident to get the wrong medication, we put procedures in place so the resident gets the right medication, and the facility listens when the resident says, that's not my medication.
And do we make referrals?
We can make referrals.
Okay. Okay, now next question. Do the speakers have any thoughts on what can be done to improve access to residents and opportunities for residents to leave or gain more space for social distancing?
Maybe Ellie, do you want to?
I was thinking about my answer. If you have something, you can go ahead and I'll just jump right in.
Well, we've been advocating with facilities to make sure that residents can have outdoor time. I mean, it would certainly be helpful in our advocacy if there were specific regulations or legislation to require that. Right now, the guidance from the Department of Public Health is just that, it's guidance. So facilities have been taking it very seriously, but facilities are not required to allow as much to have as much freedom as the guidance might allow them. So there are facilities that under the current guidance would be allowed to have visits, and they are choosing not to. Some are choosing not to have outdoor visits because their resident population can't handle wearing masks and keeping social distances. Some facility, you know, a facility that handles mostly residents with advanced dementia, that can be very difficult. But we've heard of a facility that was doing outdoor visits and decided to stop because they thought the visitors were being too rude to their staff. And while I don't condone visitors being rude to facility staff, residents haven't seen their family members in months to stop their lifeline for visitation because there were a few rude visitors is horrible to me.
Yeah, and just to piggyback off of what Suzanne had said, I agree. The IDPH guidance is just that, guidance, and it's given the facilities a lot of latitude to make the determination of whether or not they should or will allow visitation, whether it be indoors for compassionate care visits or outdoor visits. CMS had a call with all the state ombudsmen about a week or so ago and asked us what are some of our chief concerns related to what's happening in the nursing homes. And, you know, we in unison all talked about the fact of access and visitation for residents and how paramount it is for residents to be able to visit with their family members for a lot of the issues that Suzanne had highlighted before in terms of you know, just needing to see someone, to touch someone, to be fed by their loved one that has been usually feeding them or dressing them or combing their hair. So, you know, if there was anything that we could do is to push CMS to make it a requirement to allow some type of visitation for residents with their family members.
Okay, thanks, Kelly. Next, perhaps a naive question, but is the racial disparity in facilities simply a matter of cost of facilities? Example, Medicaid facilities tend to be lower quality, more people are via Medicaid?
So with the data that we analyzed, we found correlations. I don't know the exact answers on causation. There is certainly a correlation between lower quality facilities and facilities that have more residents on Medicaid, but I know that there are facilities that have a lot of Medicaid residents that are great facilities. It's harder. But also some of the data doesn't always reflect it, but some of the quote unquote best facilities, the facilities that look the nicest, sometimes are most restrictive to residents. And that, that's a quality of life issue.
Thanks, Suzanne. Could you talk about how you would handle a complaint from a resident who may suffer from dementia, but is quite vehement that a certain thing happened, but the facility staff says, no, it did not?
Well, first of all, whether something happened or not, if the resident is saying this happened and it's something that is causing them to be scared or to be whatever issue is being caused to the resident by this alleged action, we would want to ameliorate what's going on there. So, we've had facilities where a resident has made an accusation of rape, and the facility says, no, we have video evidence, we can prove that this didn't happen. Something is causing that resident to say this happened, to be scared. So let's work with the facility to make this resident feel safe.
Thanks, Suzanne. How closely do you work with IDPH?
I'll take that. There are a couple of things going on with IDPH. We have a quarterly work group meeting where all of the regional ombudsman and myself and the state staff meet with IDPH's regulatory division, if you will, and we prepare questions for them to answer. I also participate in weekly meetings with IDPH and the providers to go through issues that the providers are addressing. And it's really the provider's call, but it's an opportunity for me to get a lot of information that I can share with the ombudsman or perhaps ask questions. Because of the recent changes in administration at the Department on Aging, there is a new acting deputy. And so I'm trying to foster a relationship with this new person in order to stay in touch with IDPH and help the ombudsman program and the residents kind of work through issues. So we're trying to establish a weekly touch-base meeting where I can reach out and just go through any issues that the ombudsman have relayed to me through email or telephone calls that have been presented to them by the residents. So I'm trying very hard to have a very good working relationship and develop a good relationship with them, because I see the ombudsman program and IDPH should be kind of like hand in glove. We are the advocates, they are the regulators, and so we should be working closely together, and that is my goal, to develop that good relationship. So hopefully that answers it.
Thanks, Kelly.
Mm-hmm.
Do any of the speakers have views on the state's early pandemic action to give nursing homes immunity during the pandemic? In short, In short, I think it was a bad idea. But now, having said that, I'll give it to Kelly and Suzanne.
Yeah, I was just trying to think of how I wanted to answer that that question. Yeah, it wasn't a very good decision because of the impact that Suzanne had so eloquently demonstrated in her presentation in terms of the impact on the residents. It was very problematic in a lot of ways. So I don't necessarily agree with it at all.
Thank you. Next question. How many long-term care facility residents are able to take advantage of Ombudsman services? Second part to the question is, how many do you serve annually?
Any resident should have access to the Ombudsman program. There are a total of 1,600, roughly 1,600 facilities throughout the entire state of Illinois. And that is not just skilled nursing facilities, it's all the facilities that I had indicated or demonstrated in the slide during my presentation. And so, you know, the program is set up in such a way that the residents reach out to us. It's not us reaching out to the residents unless someone lets us know that there's a complaint. We can get complaints from any source. It just does not have to come from a resident or a family member. It could come from a neighbor, a friend, the hospital, police officers. Anyone could file a complaint with the office, and we will follow up with the resident. Again, the program is resident directed. So regardless of the source of complaint, we have to go to the resident and let the resident know that this complaint has been communicated to us. I neglected to say, but I think Suzanne or Lawrence had mentioned that confidentiality is cornerstone of our program. And so we have to have permission to act on anything that comes to us. And we have to get permission from the complainant to go to the resident and say that, hey, Kelly Richards reached out and she wanted to let us know that this was an issue for you. And we have to verify from the resident that the resident's issues are similarly to the complainant's issues. And there are times where the resident may say to us, well, you know what, that's not my issue. This is my issue and I want you to follow up on this. And so we, again, because we're resident directed, we are going to do whatever the resident directs us to do.
Thanks, Kelly. Next question. Do you encounter situations where the patient's rep is making decisions not in accordance with what's best or needed by the resident, i.e. potential exploitation? Do those issues even come to your attention?
Yes, those issues come to our attention all the time. Often they're brought to our attention by facility staff who want us to try and get involved and resolve things. So again, this goes back to being resident directed, where a resident can give us direction. If the resident says, this is not exploitation, I want to allow this, I don't want you to get involved, we can't do anything more. And that happens a lot, where residents don't want to get their family members in trouble, or they, you know, if a family member is taking the resident's Social Security money, but under Medicaid rules, the facility is supposed to have it, and the resident can get kicked out of the facility based on non-payment for not. Some residents will say, my daughter needs the money more. I would rather be kicked out of the facility than address this. And then we're done. Where a resident does want us to get involved, we can get involved, and we can, where a resident will allow us, we can get law enforcement involved. Where the resident cannot give us direction and the person with authority, the agent under a power of attorney, is allegedly exploiting the resident financially, those are complicated cases. And we, with permission from Kelly, from the state ombudsman, sometimes we can get involved, but our tools are limited where the resident can't give us direction. and the alleged abuser is their agent.
Okay, thanks, Suzanne. And for our final question, who works with facilities to ameliorate infection control issues?
So the Department of Public Health is supposed to cite facilities for improper infection control. I think that they've been trying to work with facilities during the pandemic to make sure that facilities are implementing proper infection control. There are also other resources that facilities can take advantage of to get their infection control standards up to par.
Great, thank you.
Okay, I think, Lawrence, thank you for leading the questions. Thanks to Kelly and Suzanne. We commit to end at 1:30. It's 1:29. So for those of you whose questions we did not get to, we'd be happy to get back to you with answers to those questions if you want to follow up. Why don't you just email me at jgallo@legalaidchicago.org, and I'll get those questions to Lawrence, Suzanne, and Kelly. Kelly, thank you for joining us today. Thanks for your partnership with us. Thanks to Suzanne and Lawrence for their leadership in this important space. And thanks to all of you for participating. We're grateful for your support and look forward to your participating in the next 3 webinars, the next 3 Wednesdays in September at noon.
Thank you
Thanks,
for having
everybody.
me.
Thanks,
Have a
Kelly.
good afternoon.
Thanks,
Bye-bye.
everyone.